All right. Well, my whiteboard, I don't know why it disappeared. Anyway, let's go back to the textbook. All right, so let's cover the pump failure first. So I will leave 37. I'll go back to chapter 38. All right, so cardiogenic shock signs and symptoms are here. This is page 782 of chapter 38. There really nothing new. As with any other cardiac symptoms, what are they symptoms of again, Haji?
There's a tachycardia,
Yeah, I understand.
hypotension.
Yeah, so we have them here listed on critical rescue box. This is not a chart. It's a critical rescue box on page 782. A question was, what are these signs and symptoms of? What do they require?
The signs and symptoms you can
Meaning, what's causing these signs and symptoms?
decrease oxygenation,
Remember, you
hypox.
answered it earlier that these are in response to.
Is that the hypovolemia?
No, there is no hypovolemia that results in from cardiogenic shock. Remember it on the table 37.
Okay, is it the atherosclerosis?
No, the sympathetic nervous system.
Is it
Okay,
indirect pump
so
or
these
something?
are symptoms of sympathetic nervous system response. So as soon as your epinephrine is released, this does what two things? Guys, come on. Sympathetic nervous system. What are the effects of epinephrine?
The heart rate goes up.
That's a
Heart rate
Increased
goes
the,
up.
you
friction.
got
You
a
have tachycardia.
fight or flight response.
Yeah, exactly. So, but you won't see fight or flight on the test question. So, what are those effects? So, when you have tachycardia and vasoconstriction, what are the results?
You got the increased heart rate, the
Okay, so very good.
anxiety.
Well, okay, so that's why you have here agitation, restlessness, or confusion. Okay, so
Yeah.
these are all signs and symptoms of low
You got dilated pupils.
Okay, so you have here sympathetic response. Again, the problem in cardiogenic shock is there is low perfusion, right? So there is less cardiac output that will automatically trigger your sympathetic response. That's why you have tachycardia, you have cold, clammy skin because there is generalized peripheral vasoconstriction. The blood is being shunted only to the heart, the lungs, and the brain. But because at the same time the patient is having heart failure, which led to the cardiogenic shock. So this is now the effect of shunting. You have less urine output. Your urine output should be at least 0.5 mLs per kilogram per hour, which equates to about 30 ml per hour. I already explained why your patient's skin is cold and clammy because there's vasoconstriction, pulmonary congestion because the patient is in heart failure. Okay, when you are in cardiogenic shock, regardless of if it's from an MI or from a ventricular dysrhythmia or whatever is the cause of the direct pump failure. All right, so management. This is your drug therapy for cardiogenic shock. Chart 38-7. These drugs are actually mentioned also in chapter 37. So I'll let you pick which chart you want to use. They are identical. So either chart 38-7 or there's again a chart in chapter 37 under shock, which lists the same drugs. It's a drug chart, so of course, what is the testable part of any drug chart?
Implications.
All right.
Side effects,
So,
interventions.
Treatment.
okay, thank you. So the nursing responsibilities, right? So I won't read it for you. You are responsible for reading your responsibilities. So these are nitrates. So therefore, what do these two drugs do?
Vasodilation.
Vasodilate.
Okay, vasodilation. So remember, I showed you on the whiteboard before the break. So what are we trying to do to the afterload?
To
Decrease
increase
it.
the okay.
No, decrease.
Right, decreasing. So decreasing afterload means you are dilating or constricting the vessels.
Dilating.
You're dilating. Right.
Dilating.
So those are the drugs here. The ones I highlighted are what I'm testing. Oh, I'm sorry, I forgot to highlight this one also. So Primacore, well, unfortunately, all these drugs are used for for shock, cardiogenic shock. Sympathomimetics. So sympathomimetics are drugs that mimic what?
The sympathetic,
Sympathetic
whatever.
response. Okay, so these
Yeah.
are therefore you have
Dopamine.
okay, you have dopamine and dobutamine. Okay, again, these are your nursing responsibilities. There are details here for specifically watch for nitro. So nitro medications must be protected from light. So that's why these will be wrapped with a dark brown plastic. All right. Okay. So that takes care of cardiogenic shock. Now for obstructive shock, we already did the management under chapter 32 under chest trauma. This is we're using tension pneumothorax as the exemplar for cardiogenic shock. So in the same way, the patient is going into cardiogenic shock. How did you manage the tension pneumothorax? What was the intervention?
Needle thoracic or something.
Okay, needle thoracostomy, right? So
Thoracostomy, yeah.
right, insertion of a 16 gauge thoracostomy needle in order to relieve pressure, followed by chest tube insertion. What
Yeah.
about for massive PE? Because that one also led to mass obstructive shock. What was the management for massive PE?
Atelase, thrombolytic
Okay, very
agents.
good. Okay, all right, very good. Now so we did cardiogenic shock and obstructive shock. Let's go now to, I'll come back to distributive shortly. So let's go back to 37. And let's do hypovolemic shock. Okay, chart 37-1 is a general list of signs and symptoms specific to shock. As defined, this is a whole body response, right? That reflects compensation and in response to low oxygen and low cardiac output. So it starts from cardiovascular symptoms, you have respiratory symptoms, GI, neuromuscular, kidney, and skin. Again, the way to remember these are all related
how people
to
feel when they just started a game. Those noobs.
sorry about that. That's the fever. So here you have cardiovascular symptoms. These are again specific to in response to sympathetic response. The increased heart rate and the vasoconstriction will lead to these signs and symptoms here. They're all the same effect on cardiovascular, respiratory, GI. See, the GI is the GI system a considered a vital organ when you have an emergency?
No.
No. So obviously here, are they receiving blood flow?
No, it's not.
They're not. That's why the motility decreased. Patient has constipation, and because there's less motility, the patient will have nausea, vomiting. Neuromuscular is their normal response to look at your neuromuscular function. Is it normal?
No.
No. So there is also less blood flow to those. Again, these are all effects of shunting blood. Blood is shunted from all other organs. The body is trying to shunt them only to the three most vital, namely your heart, your lungs, and your brain. The kidneys, in this instance, are the kidneys considered priority by the body in an emergency?
Yes.
No.
No,
Look
in
at
this
the
case.
effects. Okay, so are the kidneys working?
No.
No.
No blood flow to the kidneys. That's why they stop making urine. Okay. Skin, is the skin a vital organ during an emergency?
No.
No. So as you can see, everything else is not given blood. If they get any, it's very little, resulting in these signs and symptoms. Okay, so that's the easiest way you can remember them. If you want to, I don't know if you can understand these figures. This is explaining the three components that I was drawing in the whiteboard earlier. This is representing pump failure, blood volume problem, and a blood vessel problem. Anyway, I'll still just explain the concept shortly. So this summarizes again the four types of shock. So we already did cardiogenic. We will do hypovolemic next. So here under distributive shock, here you have your anaphylactic shock, septic, and neurogenic, which is in another chapter. So let's go to hypovolemic shock. So this one, which component is the problem? A pump failure, a blood volume failure, or a blood vessel problem?
Blood volume.
This
Blood
is
volume.
also blood volume. So what's the formula again for MAP from chapter 45?
Diastolic times
It's
2
diastolic plus
plus
systolic
systolic divided by
by 3.
Okay, so 2 times diastolic plus systolic divided by 3. All right. So in hypovolemic shock, since you said that this is a blood volume problem, so these are the causes, of course, are listed in this table. So any of these conditions, hemorrhage, trauma, GI ulcer, which results to bleeding, surgery because you have bleeding, inadequate clotting. So most of these cause bleeding, except this one, dehydration. This is loss of actual fluid now. The same with vomiting, diarrhea, heavy sweating, diuretic therapy, or NG suction, or in diabetes insipidus. So the first half here, obviously from hemorrhage down to anticoagulation lead to bleeding or loss of blood, and then dehydration down to DI are all loss of fluid. You can also have both. So let's say Wenister has hemorrhage as well as diarrhea occurring at the same time. So you can have loss of blood and fluid volume at the same time. hypovolemic shock is quite simple. Because you lost fluid or blood, what do you think is the treatment?
Volume treatment.
Place fluid.
Right,
Replace
simply
fluid,
you
yeah.
replace, exactly. So you simply replace the loss of blood or the loss of fluid. Yeah, as simple as that. Um, the stages of shock listed in 37-2 apply to all types of shock. Again, these stages apply to all types of shock except septic shock. Again, what does this table apply to?
All types
All
of
types of shock except septic shock.
Except septic shock. So we'll discuss septic shock last. That's why it's put in the end of the chapter, because it follows a slightly different pattern. Okay, it's different from all other types of shock, which is one reason why it has a high mortality. So in hypovolemic shock or with any other shock, the same thing as with cardiogenic, obstructive, anaphylactic, and neurogenic shock. So they follow these stages. Initial stage really isn't clinically apparent because we often miss this stage because there's not much change. Most likely, if you guys are running a marathon, um, you're probably at some point at the initial stage of shock, but because you're young, you have good compensatory mechanisms and you're still with it, you drink water, so your condition doesn't progress to the next stage. Okay, so we can skip the initial stage. We'll start with the non-progressive stage. Other textbooks. Are we back?
Yes.
Yes.
All right, where did you lose me?
You said the initial stage is often missed. It's not clinically apparent. And are we focusing on that or no?
No. Okay, so we can forget about the initial stage. We'll start at the non-progressive stage. Other textbooks call the non-progressive stage as the compensatory stage. Based on the name, what are these signs and symptoms of again? Why is it called the compensatory stage? What is the patient doing?
Mm,
Yes, Lauren?
I think guys sympathetic response.
Okay, very good. These are all effects of the sympathetic response, meaning the patient is compensating. The drop from baseline of the mean arterial pressure is anywhere between 10 to 15 from baseline, from whatever the patient's baseline is. So here clearly says continued sympathetic stimulation. So the patient has increased heart rate, and then the patient now begins having decreased urine output. Thirst mechanism is intact, and then because this is a whole body response, there is now to some extent tissue anoxia. So whenever we have anaerobic metabolism, what is always a resulting byproduct of the cells if they're working with less or no oxygen?
Lactic acid.
Right. So now lactic acid levels start to rise. That will cause mild acidosis at this point. And whenever, if you go to chapter 12, when you have an acidic pH, what will happen to your potassium levels?
potassium decrease.
I think it goes up with pH.
It actually starts to increase, right?
Yeah. Yes.
Cells are now injured because there is no oxygen available. So the pH goes down and then the potassium levels go up. If this continues without intervention, so this is your very good chance here to have the perfect opportunity to intervene for the patient, give them, of course, if this was hypovolemic shock, you would support it first with IV fluids, and then if they need blood transfusion, you give the blood transfusion. So if you give all the interventions here, we will not go into the progressive stage. So you can save the patient quickly right here on this stage. However, if let's say Wenister, while she was bleeding and having diarrhea, she was at the mountains at that time, okay, and it took her 6 hours to go up the mountain. So another 6 hours for us to go up there for the rescuers to get her, and then another 6 hours to go down. Is she gonna make it?
No.
No.
Probably not. So if Wenister doesn't get the help she needs, then she will progress to the next stage, which is now the progressive stage. Here, look at the decrease in her MAP now. She has now lost more than 20 millimeters of mercury from her baseline. So the hypoxemia and the tissue anoxia continues. Now the overall metabolism at this point is now completely anaerobic, so no more oxygen, but the cells continue to work, including especially her heart. The heart will not stop beating even if there's no oxygen available. However, all this metabolic activity is now done in the absence of oxygen. So what will happen to your blood pH?
It should go down.
Okay, so it will continue. The acidosis will now get worse, and so will the potassium levels. It will go up even more. And then finally, if she doesn't receive, I mean, there's still a chance here. If she goes into progressive stage, we can still put her in ICU, give her lots of dopamine. We'll titrate it hourly, dobutamine. If she doesn't respond, then she will go into the refractory stage. At this stage, there is now multiple organ dysfunction. So one or more organs will now start to fail, and that will be followed eventually by death. The specific signs and symptoms are in these paragraphs right here. I'll let you read it. I only summarized it from the table, but the test questions, as far as manifestations, will be grabbed from the paragraph. So I said skip the initial stage. So you start watching the specific signs and symptoms from this paragraph right here. So non-progressive to the progressive stage. My highlights don't necessarily mean anything. Those are just my reminders for myself. So you make your own highlights. Any questions so far about the stages?
No, Professor.
Okay. Just speak up if you have any questions. Signs and symptoms, this is redundant. This is already mentioned in the stages. There was a chart and then a table previously listing down your signs and symptoms. So this is already redundant. Labs. You should be familiar with your pH levels already by now. ABG values as well, PaO2 and PaCO2. I think the only thing new here is lactic acid. I know we've covered ABG values in third semester, including HNH also and potassium. These are all third semester topics. lactic acid, I think, is new. So there are two values here. I don't know which one the NCLEX will use, so I can also use either. Please take note of the values: 3.3 to 7 milligrams per deciliter or 0.3 to 0.8 millimoles. Again, I can use either one. Okay, so the values I'll use here. So let's say I give you a question on a specific stage of shock, and then I'll give you the value. Then you identify as to what stage the patient is at, or I may ask you for an intervention, what you would do. Question about that? So obviously, what happens to your lactic acid level and the pH level under the non-progressive stage?
Lactic acid is increased and pH is decreased.
All right, and then as we go into the progressive stage,
It flips.
it gets worse, right?
Yeah, it continues.
Okay.
Yeah, it becomes
And
more
the
acidic.
details, yeah, the details again are specified in the paragraphs, so you'll have to read the paragraphs as to how severe the levels are in each stage. Understand?
But it doesn't give you a number.
Exactly. So it does give you a description though.
Yeah, you said how severe. It just said like for progressive, it says rising lactic acid. So how high can it be?
Okay, again, so if I give you between, let's say, a lactic acid a level of 9 milligrams per deciliter versus 25 milligrams per deciliter, which one of those belong in the non-progressive stage?
So the 9.
The 9.
Okay.
Okay.
All right, so let's continue. Your interventions, this is specifically for hypovolemic shock. Now, there's a chart here that lists down drug therapy. Remember how you answered me earlier? If the patient loses, look at Wenister. So she had bleeding and diarrhea at the same time. How would you treat her?
Fluid,
Fluids and
I guess. Blood placement.
and blood products, right? Okay, very good. So what can you say about this drug therapy here listed in chart 37-4? Are these your first interventions in hypovolemic shock?
No.
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 And do they remind you of something? Dopamine, dobutamine, sodium nitroprusside. Where did you see this during the first hour?
In cardio, no.
These were the drugs you use for cardiogenic shock, right?
Yeah. Yeah.
Okay, so therefore, are these, again, your first line interventions in hypovolemic shock?
No.
No.
No. So these are only used if the patient gets so bad that they no longer respond to either fluid and or blood product therapy. So this is like your last ditch effort. Again, normally hypovolemic shock patients won't directly receive these drugs, only if they continue to be unresponsive to your fluid replacement and or your blood replacement. Understood?
Yeah.
Okay, I just want to make that clear. Other textbooks, by the way, do not mention these. They stick with fluid and blood product replacement. They do not mention these drugs. Okay, here. So drug therapy, in addition to fluid therapy and or blood products, is when is this given? Is used when
When there is
volume
severe
loss is
loss.
severe.
a volume loss is severe or the patient does not respond to right, fluid replacement and blood products. Alrighty. Okay, so these bullets here are your criteria for evaluating the patient, meaning are they responding to your therapy or not. So your basis for deciding, the doctor's basis for deciding whether or not to use drug therapy on hypovolemic shock depends on your findings on these criteria right here. Right, so you look at the pulse, how high is it, blood pressure, mean arterial pressure specifically, where are we at, the patient's pulse pressure, right atrial pressure or central venous pressure, the respiratory rate, skin, oxygen saturation, mental status, and of course, urine output is very important. Urine output here is evidence of your peripheral circulation, meaning if it reaches your kidneys, then that's good. I mean, I'm talking about blood, okay, or perfusion. If it's reaching your kidneys and your kidneys are able to make 0.5 mLs per kilogram per hour, then we're in a good, your patient is in a good place. Of course, these patients are really sick. All patients in shock require hemodynamic monitoring. And how can we accomplish this? How can you measure central venous pressure and pulmonary artery wedge pressure? How can you accomplish that?
Cardiac catheterization.
Okay, the pulmonary artery catheter, very good. Okay, we'll stop here. I will pause here. We'll have another break. I'll see you at 7:45.
Thank you.